So welcome everyone to the Obstetrical Hemorrhage Infomercial. This may be new for some people, but we are switching over to Microsoft Teams. And so this will be the platform that we're using. Up at the top of your screen, you will see a microphone if you need to come off mute or ask any questions. There's also a Q&A tab at the top, as well as the chat where you can chat anything in, and we can come back to it and answer any questions that you all may have. All right, and here's just a brief look at our agenda. Um, Bonnie, do you want to review of our agenda for us?
Sure. So we're going to have an introduction of the project by Dr. Tate, the overview of the AIM toolkit, the key driver, and that's with our leadership, data, metrics, and project expectations, our lovely Tanika. And of course, you all will have questions, and we look forward to them. And then minute for improvement and our closing thoughts. Thank you.
All righty, thank you, Bonnie. And so this is our faculty for the Hemorrhage Project. And so all of us got together and convened and worked really hard to come up with this project, measures, resources, to help you all along to be successful. So we will start with a project introduction from Dr. Tate.
Good afternoon, everyone. Thank you for joining us this afternoon, and welcome to the OB Hemorrhage Project 2.0, as we call it. As we all know, obstetrical hemorrhage is still a leading cause of not only maternal mortality, as we have in past put efforts towards, but now still continuing and maybe even on the rise as a cause of maternal morbidity, which brings us together today. This project's focus is going to be more on the prevention of maternal morbidity as it relates to obstetric hemorrhage. And we recognize we are a very diverse state and we have systems that have diverse needs. But the goal of this project is that we can all be centered focused on ways and strategies to make sure that we are organized and our efforts are organized in preventing significant hemorrhage. We know it's one of those unpredictable natures in the care of an obstetrical patient, but readiness is really important, recognition, right? And then our response, our three favorite R's as we talk about quality improvement. And you'll see how we'll be able to apply that easily. Our goal here is not, of course, with any project to be too burdensome, but with something that is definitely relevant to all the work we do as we care for our patients, having that smooth transition to, again, that more organized effort so that we can see continuous improvement in the outcomes for our patients all across the board, especially in the hemorrhage area. So thank you all for joining us today.
Thank you, Dr. Tate. And we will get started with our toolkit overview. And so we'll have a lot of people weighing in on this and we'll get started. First up with Bonnie.
Hello, everybody. Thank you for joining. So our state aim is to improve the care and outcomes for pregnant and postpartum women who suffer from an obstetrical hemorrhage by achieving 90 to 100% compliance on both of the following: the utilization of a postpartum risk assessment, which is in Appendix 3, and measuring blood loss cumulatively and quantitatively for all births by January 2027. Next. So our toolkit and potentially better practices is all on the TIPQC site, and we have all the education stuff that you could use. And if you come up with something, we would love to put it in our resources. But it goes by hemorrhage readiness and our QBL versus EBL, evidence-based medicine, and then patient event debriefs, and then management of anemia. We worked really hard to as a team to put this together for you all. Next. So your hemorrhage readiness. Having a standardized hemorrhage management. The protocol standardizes the recognition, management of obstetrical hemorrhage for consistent evidence-based care. Rapid multidisciplinary response. It's how quickly you can respond, get your mass transfusion protocol, hemorrhage protocol, all of that activated. Defining the roles and responsibilities, making sure there are clear role definitions that foster a shared accountability among your obstetric, surgical, anesthesia, and your blood bank teams. And of course, education and awareness. Ongoing training ensures all team members understand when, how to act. Next. The definition of postpartum hemorrhage. Postpartum hemorrhage involves blood loss of 1,000 milliliters or more within 24 hours, or any bleeding causing hypovolemia symptoms. And if you want to use the CMQCC algorithm when it comes to blood loss, it's a really great one. And it helps pre-admission, then their stages and things like that. That should hopefully be in your EMR. There we go. Hemorrhage cart essentials. Oh my gosh, having a hemorrhage cart that somebody can grab, or even a toolbox, tackle box, whatever, fully stocked. And it doesn't have to have the medications in it or the fluids. Those have to be Infomercial being available to get rapidly. But having all of the things that you would need, a Jada, Bakri, things like that, is so important to where you're not having to go out of the room, in and out multiple times to get supplies that you need. Grab a cart and go. Next. So the massive transfusion protocol, it is a process where rapidly administer large blood volumes. And we all know that we can drop some blood really quick. But does your hospital have one? And how much blood can you get at one time? The NTP activates when blood loss exceeds 1,500 to 2,000 milliliters. If the patient is dynamically unstable, and if they're not stable, don't wait till you get to 2,000 milliliters. You all know how to judge it, the risk assessment and all of that. You're going to be great. And then the importance of early escalation, clear activation criteria, which reduces hesitation. And always say this, you can always call a hemorrhage, and then if you have to call it off, it's better to call one early than to not call one at all. Next. So your team, activate, I think that repeated. Is that same? Recognize the triggers. Get your balanced transfusion, uses a ratio of red blood cells, plasma, platelets, cryo, and manage that. How much blood can you get with your blood bank? Monitoring and reassessment, continuous hemodynamic monitoring and frequent lab reassessment is, there's a guide to that therapy, and it prevents the complications for later coagulopathy. In communication and coordination, say it out loud. It's okay, the patient knows that they're hemorrhaging. They need to know. Do you need the operating room? Tell people out loud what you need. Again, you can cancel things, but not saying them out loud does not help you, because it doesn't allow other people the opportunity to help you. Next. Our toolkit also has the hemorrhage risk assessment. This is the A1. It gives you the risk category upon admission, then during the labor, and then postpartum. You also have to think about what was the antepartum bleeding. All of that becomes cumulative over a period of time. So knowing that your low, medium, and high risk assessment is going to help you to anticipate if there is a hemorrhage, how can we be ready for that? Next. And this one is your pre-birth, right before birth. Were you given MAG? Were you the patient on Pitocin for over 24 hours? What else was going on with this patient? Were they have the hypertensive emergencies during this time? And this will help guide you through that as well. Next. And then there's your admission to postpartum. All of these things are in the toolkit and available for you to utilize and have added to your EMRs if it's not already available. And I do know that if it is available at one hospital like Cerner or Epic, then you have the ability to have it added to your EMR as well. Next.
right, let's see. Hopefully this loads up. I have a minty in here.
Yeah.
Just part of it. It will work for me today. All righty, perfect. If you'll scan the QR code, or you can go to minty.com and type in that code. Just trying to break things up a little bit. And just let us know which of these hemorrhage risk assessment tools does your hospital use? Sorry, there's word missing. So we have the CMQCC version, A1. There's also one by ACOG Safe Motherhood Initiative, or maybe you're just not sure what yours is based off of. Right, so we have 50% that aren't sure, and then we have 42% that are using the A1. So those that aren't sure, that's a little homework assignment. Go back and see what yours was based off of. And then we'll switch over to Dr. Tate.
Thank you.
Thank you, Tanika. And just to pick up where Bonnie left off, and I can't emphasize enough the importance of that effort of cumulative blood loss calculation. I think a lot of times in our care, especially in the inpatient setting, it can be fragmented, right? A patient comes in through the triage area or admissions. That's one moment, the labor and delivery experience, and sometimes labor versus delivery and right after. And then the postpartum experience, we're having 3 sets of staff, 3 locations that could be very much so on opposite sides of the hospital, and 3 kind of thoughts of and approaches to bleeding. So it's really important to make sure we are capturing every moment of significant bleeding, and also accounting for anything we can accumulate and count for prior to the patient's arrival in an emergency situation. And then even that going home moment in those first few days, especially after delivering up to a few weeks, because we know that even in an acute moment, yes, of course, we have acute blood loss and that could be significantly impactful to health, but the collective over time can take a toll on the patient's health. Most of our patients are healthy and young, so it does take a significant moment. I call patients oftentimes cliffs, meaning they're fine and then they're just all of a sudden not. But when we look back at the recent history, we oftentimes can find that the collective would have told us a better story. So definitely using those checklists, whether you print them, whether you incorporate them into your electronic medical record, whether you have someone designated as that person, but always real time as patients moving through the system using that checklist. And what I like about the A1 checklist is it also gives you guidance on how to be proactively preparing for the potential of a patient hemorrhaging based on her risk assessment. So it kind of gives you that first footing to step off and move towards preparing for a safer birth experience. And so the next level of that in the discussion is always how do we calculate and add up the blood loss that a patient experiences during, especially the birthing experience. And there's always the discussion of, is that traditional estimated blood loss hold the value and weight that we think? Or is it better to move towards quantitative blood loss? And as we know, and those who've done the work in this area know, quantitative blood loss does prove to be more significant and valuable and accurate when you think about it. We give ourselves credit where we probably shouldn't, and we are always thinking we're accurate with the estimated, but it's been proven time and time again that we're not as accurate with estimating blood loss as we think. And most times we will underestimate the loss and then sometimes scratch our heads when we're trying to understand why someone is showing signs of severe anemia when we didn't account for it. So what's the difference between the two? First, we understand how it's done. The method of estimated blood loss is basically what we visualize. And we have to remember that's blood in any place, whether it's a lap or on the floor, in the under buttock drape, or on the patient herself. What we're collecting from the womb as it's exiting. All that counts. And then quantitative blood loss, however, is different. We're measuring it, right? We have standards. We know what blood should weigh. We know what the items that can't hold the blood or collect the blood should weigh, and we're able to get that accurate number, right? So when you look at the accuracy between the two, we know for a fact that estimated blood loss, as good as we may think we are, is still poor in comparison, where quantitative blood loss is going to have that high accuracy that we're looking for. In terms of bias, it's very hard to be biased with quantitative blood loss because it's very objective. It weighs what it weighs. The numbers are the numbers. However, again, that layer of underestimating that comes with estimated blood loss, especially in large volumes. Estimated blood loss as well is very hard to reproduce, even in the same person. You could probably have yourself go back and check the same amount of bleeding, and you may give a different number every time. And you think about a group where everyone's looking at the same amount, it's going to be a lot of variation between the doctor, the nurse, the midwife, the anesthesia person looking as well. Whereas quantitative blood loss, because we're using weights, is very standardized. As long as your equipment's working, you should get the same number every time. And then when we look at who's recommending it, when we look at all the gurus of this work, everyone, ACOG, SMFM, AIM included, are saying quantitative blood loss is the most accurate way to approach versus that estimated blood loss, which is no longer recommended by any society for best practice. Next slide.
And we'll just throw in one more Mentimeter. So what method do you use to track blood loss at your hospital? Are you using EBL, or are you using QBL, or are you doing the cumulative QBL where you're going through recovery as well? And so you can scan the QR code or go to menti.com and type in that code. Okay, so it's not tracking over here off to the side, but we have, okay, so we are 33% all the way across. So 33% using EBL, 31% using QBL. Okay, we're moving on up for cumulative QBL with 43% of people using cumulative QBL. There it goes. Perfect. Back to you, Dr. Tate.
Thank you, Tanika. And I would highly encourage everyone, as an exercise with your staff, with your providers, just doing a head-to-head comparison. Sometimes we have to see the reality of it. And it doesn't mean that being spread across the board is a bad way to start in any way, but it definitely gives us areas to focus to move towards a more uniform effort. When we talk about evaluation of maternal care level as it relates to hemorrhage, it's important to know that the hemorrhage risk directly influences the appropriateness of the maternal level of care assignment, meaning being proactive, we're coming in saying, if this is a high-risk patient, we know we need a higher level of maternity care, and that may require for a lower level hospital to move a patient prior to even delivery or at the start of the change for safety reasons. It's important to note as well, if there's a failure to match the hemorrhage risk, then there is a possibility that this lack of timely movement can be a major contributor to both maternal morbidity and mortality. And again, things like the checklist that we've discussed earlier will definitely help your facility to recognize very early that you may not have the resources available in the case the patient does deteriorate or there is a hemorrhage situation, and moving early is not at all an inappropriate plan. Next slide. So when you're evaluating for maternal level of care, remember that those at highest risk for hemorrhage are going to need the following, and that's the ability to have not only blood products available, but the ability to replace rapidly in the case. And that's usually through a massive transfusion capability. You may have a protocol, you may not, but just the ability to have the resources to give it a rapid fashion. Obstetric anesthesia is really important because they are going to oftentimes be your captain and lead of that effort of replacement, but also understanding the needs of what the replacement requires and the order, as well as the pace of replacement, is usually at the head anesthesia leading that effort. Interventional radiology is always great to have, especially in the situation where you're having hemorrhage related to, say, uterine atony, and they have the ability to potentially safely move the patient to their suite or come to you to help with efforts. And then having the ability to have your GYN specialist, your trauma surgeon, anyone that may need the surgical specialty efforts, they are available to do so. So say it's a cesarean hysterectomy, or you recognize there's trauma to organs nearby, like bowel or vascular structures, having them available to come into your operating room is important. And then ICU level care, right? Once the event's over, most patients do need certain time in the ICU to recover and have that close watch. And so as you're building your protocols, if you don't have them already for transfer, keeping these things in mind if you don't have those resources, and if you have some and not others, which ones absolutely would trigger, if needed, the ability or the plan to move sooner than later. Next slide. All right, we're going to switch gears a little bit to talk about medication administration. And I'm just going to fill in for Dr. Ennis. He was not able to make it today, just to discuss very briefly those medical management agents you can use and help correct with hemorrhage as you are caring for the patient. The first is oxytocin. We're very familiar with this one. And remember that increases in the translunar calcium stimulating muscle contraction. So basically what it's doing is coming in and helping the womb to contract down. Typically you're giving this at an IV infusion of 10 to 40 units per 500 to 1,000 milliliters. Or if you don't have IV access to do so, you can definitely go the route of 10 units IM, typically in the buttocks or upper thigh area. You also have the ability to give Methergin. Remember that, as well as one that is going to increase tone of the uterus or the womb, also the rate and contraction amplitude to help give that force to contract down the smooth muscle to help with bleeding cessation. It is also given IM. You can give it every 2 to 4 hours. And remember, the biggest side effects with it is if someone has a high blood pressure history or currently has preeclampsia, we don't want to give that to further exacerbate that issue. If it's given IV, it can worsen the side effects that we don't want to see. So typically given IM. This is also a point if you're cycling through many medical agents, to have someone's job to just track when things are given, because it may go past enough time where you can give an agent again if it's thought to be helpful. Next slide. Hemabate is our next agent. Again, goal is stimulating smooth muscle, uterine contractions. This one is also given IM or through the muscle, or you can actually injected directly into the myometrium or the wall of the uterus to help with contraction. So that's something that can be passed sterilely in the operating room off to the provider, the physician. This can be given every 15 minutes for up to 8 doses. Typically, we avoid this when someone has a history of asthma or any serious respiratory history. Misoprostol is one that can be given to induce uterine contractions, as we know as well, because we give it as an induction agent, but we would give it in larger amounts, up to 1,000 micrograms, orally, sublingually, vaginally, or rectally, whatever is most fitting. This one does take the longest to kind of kick in and start to work versus your others. So most times in a hemorrhage protocol situation, you may be able to only give this one time, if that, but keep in mind, if it's given as the first agent, you will likely have to do other measures to continue to help aid in the bleeding stopping before it really kicks in to give its effort. And just one little pro with it as well, it is known to give or to cause fevers within the first 24 hours of giving it. So if you have someone spike a fever, just continue to monitor that, as it may be medication effect. Next slide. All All right, tranexamic acid or TXA. I know it's one of the newer ones for people who've trained as long as I have, but definitely a great one to use in the setting of hemorrhage. Also really great for prophylaxis. And I know a lot of systems will use this for patients who are going back for unscheduled C-sections or emergency sections to help with bleeding, as well as right after delivery for prophylaxis. It displaces plasminogen from fibrin to help with the bleeding cessation or slowing down. So a different approach than the medications we've talked about before. You can give 1 gram IV over 10 to 20 minutes, and that can be repeated after 30 minutes as well. So again, having your timekeeper and your rolling list of what's been given to circle back will help in the situation. Next slide. Shifting gears one more time before I turn it over to Dr. Garrison. Let's talk about management of anemia. I think, we are so used to in the OBGYN world seeing anemia, but seeing patients overall appear healthy, it often falls to the side as part of the discussion of hemorrhage and pregnancy especially. It's really important to first know where normal sits. When we look at ACOG diagnostic criteria, and this is per the practice bulletin 233, we should expect that a hemoglobin of 11 is really the goal. So they define anemia in the first trimester as a hemoglobin less than 11, second trimester less than 10.5, and third trimester less than 11. So why would that be different? Because naturally there's hemodilution as part of the normal changes of pregnancy, and that hemodilution is greatest in the second trimester. So naturally, we expect the hemoglobin to be lower. I know many of our systems are fans of hematocrits, but remember that's a calculated value. So to be your most accurate, you want to know what a hemoglobin is on a patient to say it's normal. So why would ACOG tell us this? So that as a patient's going through the pregnancy and we're prepping for delivery, our goal should be at least a hemoglobin of 11 going into delivery, hopefully higher, so that if there's any significant bleeding, it won't further increase the risk of morbidity and mortality just based on her coming in with a lower baseline. Now, WHO follows that, and they say basically anything less than 11 at any time in pregnancy would be considered anemia and should be treated. Next slide. So how do we correct anemia, or why do we correct anemia first? And the first thing is it improves the ability for mom to pass oxygen over to baby. So it improves maternal oxygen carrying capacity. As we all remember, hemoglobin is the vehicle that moves oxygen around the body. It's also going to increase the ability for the patient to withstand delivery-related blood loss. If we start higher and we have a major loss, more likely for the patient to withstand this, maybe also reducing as well the need for emergency transfusion or even transfusion at all. It also lowers the risk of having a patient decompensate because of loss, right? If she's anemic and becomes severely anemic, more likely to go into shock and have a severe decompensation. And then as well, it will enhance the other agents that you're using in your hemorrhage response, such as your medical management. They'll actually work better when you're looking at correcting anemia. And we all know anemia is most often corrected by oral supplementation with iron. Key facts to know when you're giving someone iron, make sure that they are taking it with vitamin C and avoiding dairy, because those things will actually help and hurt the ability for oral. If you're at the end of pregnancy and time is winding down, consider IV iron infusions. They're also really great for those patients who can't tolerate oral, and they work faster to get that correction going. And then, of course, if there's ever a situation where a patient's in the antepartum period or near delivery and she's coming in so low, it's definitely harmful to the pregnancy, blood transfusion is never wrong. And we typically in the high-risk world talk about blood transfusion when you have a hemoglobin less than 7. When we get to 6 or less, that's when we have the potential of having loss of the pregnancy or growth restriction or even severe maternal morbidity related to it. So as your patients enter into even the delivery admission, being proactive with transfusion would be definitely worth it if they are at a 6, 7, or even an 8. because you're correcting and also being proactive for their health. And I know that kind of gets a little tricky with numbers and counting with reporting, but remember, we're always doing what's in the best interest of the patient at all times. All right, I'm going to turn it over to Dr. Garrison to finish us out with our toolkit highlights.
Thank you, Dr. Tate. So I thought I might just kind of start with a reference to the AIM toolkit. And the reason that I included this is because it really lists four processes that are designed to evaluate, to improve our ability to assess our response to a postpartum hemorrhage when it occurs. Each process can help us communicate with the patient, think about our team performance, and optimize our clinical outcomes. And then perhaps most importantly, identify opportunities for education and system improvement. So the four processes that they recommend that each team include in their overall management of postpartum hemorrhage include a patient event debrief, a clinical team debrief, multidisciplinary case reviews, and patient education. And when you look at all four, there are several that I think most, if not all of our teams do routinely. And there's one that you may not even think of as a process, but you could use this hemorrhage like quality improvement sprint to really think about how you offer one of these and to think about how you can optimize it, one or more of these, and how you could optimize it. So the clinical team debrief is that just-in-time discussion that you have with your team after a postpartum hemorrhage occurs. And ideally, it should be offered before the end of your shift so that all of the key members of the team who are involved in managing the postpartum hemorrhage have an opportunity to discuss the case. They can discuss what went well, what was challenging, and really identify some structures or some process or education that might make a management of the hemorrhage the next time it occurs a little bit better for the team and for the patient. The multidisciplinary case review is that secondary level of review that happens well after the event has occurred. And that is where you, again, have a multidisciplinary team review the records, review the overall patient outcome, and compare that case to others so that you can really identify opportunities for system level improvements that are going to make a difference for all of your patients with a postpartum hemorrhage. So often with the multidisciplinary case review, you can review the chart, but having that just-in-time debrief provides that secondary team with additional information that can be key that may not be included in the chart. And then you have patient education, which of course is so important. The toolkit that we've developed really is a great one-stop shop. If you look at the resources for patient education, there are multiple links to resources from ACOG, AIM, CMQCC, A1, and others. And we are designing that resource section so that it is a living document, so that as you identify additional resources, you can share them not only with your team, but with others. The last process measure is the patient event debrief. And this is something that we do routinely where, after the hemorrhage has occurred, we talk to the patient and the family about what happened, the patient's risk factors for it, whether the risk factors were known or not. And then we talk to the patient about next steps. This quality improvement sprint can give you and your team an opportunity to really think about education of the team around that post-event discussion. And it can help you think about opportunities to perhaps standardize that. There might be a dot phrase that you might want to add for your clinicians so that they can document that discussion in a uniform way. Or there may be onboarding of new faculty, new staff members, new nurses to your team. And all of us have a role to play in making sure that the patient has the best information about what happened and next steps. And this won't replace your disclosure discussion, but it is just really a standard part and parcel of how we communicate with our patients and on a day-to-day basis. Next slide. So this is the clinical, just a general example of a clinical debrief form of, what went well, what didn't go well, what are some opportunities for improvement, and then ask questions about communication. Was it clear and effective? Did everyone have appropriate situational awareness? Did you really know what was happening and why? Did you have a clear idea of what your role was when the event occurred, and what could have made that communication a little more seamless for the team? Next slide. This is a hemorrhage team debrief form, which may be a little different from the universal form, but it has some questions that you could consider incorporating depending upon the your postpartum hemorrhage volume and the acuity of your unit. But in a debrief for postpartum hemorrhage, you may want to include some documentation of the procedures used, the uterotonics used. Were there any tamponade procedures used, like the balloon or the Jada? Did the patient go to IR? Was the OB hemorrhage cold called? And did the team respond as expected based on any of the checklists that you're currently using? So it really is a great way to kind of think about what happened, and based on your blood loss, did the team respond as expected? And knowing that there will be some variation, but it gives you an opportunity to really think about were there interventions that could have been employed earlier, and if so, what can we learn from the current case that we can apply to the next one? Next slide. This is information about the case itself that you can have someone who's leading the team debrief fill out. So it doesn't have to necessarily add to the time of the debrief, but again, it gives you some information about what happened with the case. And then the next slide. And this is kind of your general discussions portion of that debrief of like what went well, what are the opportunities for improvement, and what additional feedback does the team have for leadership, so that all of the information can be considered when you have that formal multidisciplinary review. Next slide. The discussion with the patient is, again, one that we all offer, but it may not be formalized in the sense of you offering training to your staff about how to have that discussion, and really thinking about, is there some language that you could have in your, either on your badge or in your pocket or in your EMR somewhere that might help to make that discussion easier for you. So spikes is a mnemonic. I did not come up with this mnemonic. I think our great Bonnie Miller may have included this in your toolkit, but I think it's a wonderful mnemonic that you can use to remember to help guide you when you have this discussion. So SPIKE stands for setting, having the discussion in a private place, a quiet, uninterrupted space. Perception, and that is your reminder to really assess the patient's understanding of what happened. And then invitation, and that is when you really ask the patient or the family member what information they would like to know more about, and what level of detail they would like, and what are the main questions that they have at this point, knowing that their desire for discussion will change over time, but this really opens the floor for you to better understand what the patient or the family member want to know, and for you to make sure that you answer those questions. And then knowledge is sharing the facts in a straightforward manner. E stands for emotions, really validating their feelings, their concerns, and then strategy, which is perhaps the next most important thing of just outlining what are the next steps. What should the patient or the family member expect, and what kind of support will you offer them along the way? And it could be as simple as we'll have a nurse check on you every 4 hours. If there is any additional bleeding, this is your call light. If you have any concerns, feel free to let your nurse know. Please feel free to make a list for the team. You could go on and on, but really going through the strategies for support and evaluation as the patient recovers are going to be key. Next slide. And this information is in your toolkit along with some sample language that you could consider as you train your team. This is a form that's in the CMQCC toolkit, and we'll include a copy in the TIPQC toolkit as well. But it is designed for the patient, and it's something that you can certainly include in their chart, but you could give them a copy as well. And it really describes, gives a little detail about what happened. How many units of blood did the patient receive? Were they in the ICU? And if so, for how long? At the time, we always think that our patients remember this, but often after the event, and the further away you get from the event, it can be difficult to remember details. And this information may be buried in a discharge summary. And it is also always nice to have something that is separate that really describes the severity of the issue and the team's response. I think the follow-up section is helpful because it really clearly delineates the subspecialists that the patient may or may not follow up with, support groups, social workers, any point of contact for the team that you plan to have the patient follow up with, you can list there. And then you can include a clinic phone number. And at the end of this form is really just a general patient-friendly summary of what happened and next steps that you could include if you want. But this is something that could travel with the patient, and they can use it for their next pregnancy. And it may be a little more detailed than the patient's recollection of the event. Next slide. Patient education. There is a wealth of education within the toolkit, so many links that you have an opportunity to explore and use. TIPQC has developed a wonderful one-page hemorrhage document that can be used before the patient delivers, just to review the bleeding, the risks associated with it, the risk factors. It reviews your hospital's approach to the evaluation of her bleeding. It tells her what to look for and the various treatment options that are going to be employed during labor and postpartum. The diagram on the right, it should be familiar to you, and this is from the CDC Hear Her campaign, and it can be used prior to delivery as well as after. I think the warning signs are universal, and it can be something that you can include in the patient's summary after her outpatient visits. You can include it in her discharge paperwork. You can send links. They have TIPQC has magnets, so this is something that you can use freely and often. I think it's a wonderful resource. Next slide. This is a slide that was taken from, yes, it's in the CMQCC website, and we'll include a link to it in the TIPQC toolkit as well. But it provides a little more information about that postpartum recovery for patients. And I like it because not only does it talk about the physical recovery symptoms that a patient may have, but it also, if you go to the next slide, it also goes into the emotional aspect of this as well. And patients that have a postpartum hemorrhage are at risk of PTSD. They're at risk of worsening anxiety. And so giving the patient the sheet or using this sheet as an opportunity to really discuss the impact that the delivery and the subsequent management of her postpartum hemorrhage may have on her emotional recovery from the delivery is great. I think to the extent that we can normalize those feelings and offer the patients resources that are going to be helpful, that is key. And you can use this sheet to educate the patient and her family members so that they all have an idea of what to look for and next steps, who they can contact on your team if they have questions. And I think that is it. We'll go to the next. Oh, last. This is just for if you use the sheet, you've got when to call and steps to success for the patient. So it really just kind of helps the patient understand that you are there and your team remain available for support while she's in the hospital and in the postpartum period. And we'll go to the next speaker.
Thank you, Dr. Garrison. So yes, all of these wonderful resources are available for you all. We have them in our toolkit as a reference list. There's also an EMR guide that was created. Simple QI will have lots of resources uploaded to it, and then you have all of us. This is just to look at our key driver diagram. So we broke it down into the readiness, the recognition and prevention, and then response reporting and systems learning, and just wanted to tie all of that back into our state aim. So we're going to skip this question part for now, and we're going to go into data. So data collection for the project. So we will be looking at outcome measures and balancing measures monthly, and then quarterly we'll look at process and structure measures. So we're using Simple QI again for this project. All team members can view their data in real time. You can download this data. You can download the graphs and use it for whatever you need to. You can also create your own measures that you want to track at your own hospital, separate from what we're tracking for the project, and have those as well. And then you all are able to add whoever you want to on your team. And so when looking at our outcome measures that are monthly, we're going to be looking at, as Bonnie said, the percent of birth admissions with a completed hemorrhage risk assessment documented. And then also looking at that percent of birth admissions with documentation of cumulative and quantitative blood loss from birth through recovery. And our outcome data for the project will be stratified by race, ethnicity, and payer status. And then, of course, when you show improvement in one area, you don't want other things to kind of start slacking or teetering off. You just want to keep an eye on those. So for balancing measures for the project, we are going to look at the percent of ICU transfers due to a maternal hemorrhage. And so that will be, we're using the definition of blood loss greater than or equal to 1,000. And so also looking at the percent of patients that have the massive transfusion protocol implemented. And then the percent of patients who require surgical intervention due to a hemorrhage. So thinking more so on the lines of like a hysterectomy, having a B-Lynch placed, having a uterine artery ligation. And process measures, we'll be looking at the number of unit drills, but also looking at the topics that are covered. So are those related to hemorrhage, severe hypertension, or are there other topics that are being covered as part of your drills quarterly? We'll be looking at the percent of education provided to OB providers, and then the percent of education provided to nursing on obstetric hemorrhage. And structure measures. We're looking at a hemorrhage cart. Do you have a hemorrhage cart in place on your unit, but not just on labor and delivery? Do you have this on your postpartum unit? Do you have this on your antepartum unit? Do you even have a somewhat of a hemorrhage kit in an emergency department in case a patient came in and could not make it up to your unit in time? Do you have everything that you need in every area that a pregnant or postpartum woman would touch? Then looking at those unit policy and procedures. So looking at that rapid response team. Do you have a standardized stage-based approach? Do you have that emergency release and massive transfusion protocol? And then do you have a protocol in place for patients who decline blood products? And so this is pulling all of these policies, looking over them. Had they been updated in the last 2 years? Do you have a department that you would like to add into this policy and procedure now? Have there been updates to your paging system that need to be updated on here to reflect? So just making sure that everything's up to date and that anyone could walk on the unit, pull one of these procedures, or policies, and be able to follow it to a T and get the response that they would need. And then also looking at that quantitative blood loss, like do you have everything that you need in order to measure blood loss quantitatively? We're also looking at the patient event debriefs, the clinical team debriefs, the multidisciplinary case reviews, and the patient education that Dr. Garrison covered for us. And then as part of all of our projects, looking at that patient and family partner implementation, do you have someone as a voice who can look over your resources that you're given, who can look over these policies and procedures. I think they would be really great to have, especially for blood loss, for those who decline, have them look over it. What are their thoughts about it? Like, how would that make them feel in the way that you approach them? And then, of course, all of these will all spill back over into our recognition awards criteria that we have for every project as well. And so there will be an option for 6 stars. And so the project and team expectations. So our general structure for our projects are we have those monthly huddles. For the Hemorrhage project, they'll be on the fourth Wednesday of the month at 1 p.m. Central, 2 p.m. Eastern, with the exception of November and December, just due to the holiday weeks that we would fall on. And we ask that each team be ready to share their monthly reports, submit your data in simple QI, and also submitting a monthly leadership report. And then when we go over quarterly, having coaching calls with us, reviewing your progress on your project metrics, and submitting your quarterly data in simple QI as well. And so as you get ready looking at the project, we've had a lot of applications. I think we're up to 17 or 18 so far for the project. But if you haven't applied yet, just go ahead and assemble your team. Who's going to be that day-to-day leader for the project? Who's going to be your data contact? Do you have a nursing champion, physician champion, a senior leader, and that patient and family partner, just because everyone plays a different role for the project? Our tentative timeline for this project, we are having our statewide launch September of 2026. Data collection would start for those who are not in our pilot in October. And then we were going to call this a sprint at first, and then we got into it and decided that there was just so much work that needed to be done for this that we decided to extend it. And so we will be going into sustainment hopefully in March of 2028. If you are at our annual meeting, we had some hospital engagement posters that we passed out. These are just looking at for the project, improving the care and outcomes for obstetric hemorrhage, just kind of reviews over our why as a state and why this project is so important for us, just because between 2018 and 2022, hemorrhage accounted for 34% of severe maternal morbidity indicators. And so, SMM, I feel like everyone's looking at their SMM rates, and we should be. And so we worked on a quick film, and I think one of our stars of this film is actually on the call, and hopefully this is going to work. So let me know.
Tanika, it's working, but there's no volume.
Okay, let me reshare then, Brenda. Thank you.
Absolutely. While she's doing that, this is Brenda, our director here at TIPQC, and I just want to say you may feel overwhelmed hearing all of this. As Tanika said, we've got the next 1.5 to 2 years to embed all of this. So please don't feel like it's an elephant. You have to eat it all at once. It's one small bite at a time. Hopefully she's got that ready. But we're so glad that you are joining us and really know that this project is going to make a huge difference for our moms across the state. So thank you for joining us, for your interest. And back to you, Tanika.
Thank you, Brenda. I'm going to try it now. Just let me know if it's working for you.
Yeah, still no volume. I think it may be setting up WebEx at the beginning to have the volume. It's kind of up there on the top.
Yeah, I shared it that way, and for some reason it's still not working for me, unfortunately.
Well, we can send that out as well. It's a great video, and we can play it next time too.
Yes, absolutely. Okay, and then we'll have Bonnie review over the next steps for the project.
Next steps. Magical. So the next steps are to make sure that your team was registered for project. Look over the toolkit. Thank you, still not sharing. And then if you have any questions, thank you. Complete your application, submit your DUA if needed, complete your baseline survey in REDCap, and then when you get your login, log into Simple QI and look over it, get a review, and if you need one of our data people to go over it with you, they'll be glad to schedule an appointment with you during their business hours and review it. Next. Statewide hemorrhage huddles, September the 23rd is our state kickoff. And we have October the 28th, November 18th, and December the 16th. So put those in your calendar. You'll also get invites to remind you. Our team is really good at sending out gentle reminders. And so it'll be from 1 to 2 Central Time or 2 to 3 Eastern Time. Next. Now, if you have any questions, what, where, why, when, any kind of questions you have for us, please feel free